Hello everybody, I am Professor Dr. Sumit Chopra. I am heading Department of Oral and Maxillofacial Surgery in Himachal Institute of Dental Sciences, Paonta Sahib, Himachal Pradesh. We are also having a postgraduate program from last 8 years, and we are actively into academics and research and different kind of surgeries. And today we have a very different case of management of deficient alveolar ridge. The patient visited many dentists earlier, then finally he was referred here to our college. The patient was initially referred to orthodontic department for the correction of malaligned teeth, but he had a big edentulous span, though the patient he's quite young, so he wanted to have replacement of the missing teeth. Congenitally, the teeth were missing. There are many missing teeth congenitally. So the area is also very deficient. The width is also very compromised. There are different ways how we can restore or reconstruct the ridge. We usually take autografts from the symphysis region, from the ramus region, but this patient requires bigger grafts because the area to be restored is quite big. So it cannot be done with the local grafts. So we are planning to take graft from the iliac region. So this surgery we have planned today, and we will be doing under spinal anesthesia and local anesthesia. We will discuss about the surgery a little later. Let's go ahead. This is how we have placed the incision. So we have placed the incision in such a manner that after the closure, the suture line should come towards the lateral side. It should not fall directly on the alveolar crest. As you see, we have done reflection very carefully so as to protect the tissues both from the medial and the lateral side. This is how we have scored the harvested site with chisel and mallet. We have to go deeper. So that we can take a good thickness of cancellous bone along with the overlying cortical plate. Now we will finally separate the graft from the underlying bone very carefully. This is the graft that we have taken. It consists of cortical plate and underlying cancellous bone. For storage purpose, we will immerse the graft in gauze soaked with saline. It should be dipped in the saline. It should never be left to dry. Regarding the oral cavity, it has to be infiltrated with local anesthesia with adrenaline. We have placed a full thickness crestal incision with releasing limbs. The incision is sufficiently wide enough to accommodate the entire graft, and there should not be any chances of exposure after closure. The closure should be done very passively. That is how we have planned the incision. Reflection is done with a lot of care so that there is no laceration. Before fixation, we have to make sure that the graft matches the size of the recipient bed. So we will trim the graft wherever it is necessary. Contouring has to be done according to the morphology of the recipient defect site. Fixation of the graft is done beautifully using 4 titanium screws so that the graft is nicely fixed and it should not become loose after the fixation. Closure is done in a very passive manner using interrupted vicryl sutures. Pressure bandage is given to reduce post-operative swelling. So this is how we have come to the end of our surgery. I thank the entire team, the anesthetist, the staff, the postgraduates, the interns for their kind cooperation. Thank you all.